thanks everybody for being here. And it is my pleasure to introduce our speaker today. We have Dr. Hayley Root, who's an assistant clinical professor at Northern Arizona University. And she's here to talk to us about her research as an athletic trainer, but how that intersects with public health. So thank you, Hayley, for being here, and take it away.
Hi, thank you. Hey, everybody. So I appreciate that intro, and I'm just going to give a little bit more context first on kind of my background in both athletic training and public health, because I think kind of that journey, if you will, sort of informs what I do now for research. Most importantly about my background is that I'm from Atlanta, Georgia, and the Braves won the World Series last night. In case you missed it, just wanted to take that opportunity to shout it from the rooftops. Okay, so more relative for my background. So I majored in exercise and sports science in undergrad with a concentration in athletic training. So this was kind of my first exposure to athletic training. I knew that I wanted to do something healthcare wise, and I kind of stumbled upon it one day. And after I graduated, I wanted just a little bit more experience and exposure to athletic training in kind of a guided way. So I decided to get my master's and moved up north for a little bit. And what's important about my master's is that my grad assistantship was with a junior boarding school. So this was 4th through 8th grade. And these students were required to participate in physical activity every day after school year round. And this was a really different kind of athletic training for me. In undergrad, it was much more, they're very competitive D1 athletes. Most of the people are trying to make it professional in some way, shape, or form. And now I was working with, 10 to 14-year-olds with varying levels of interest in physical activity. So it became a lot more health education and wellness and kind of teaching people about their bodies and injuries, because for a lot of them, it was the first time they had ever been injured and things like that. So this was kind of where my interest in youth sport came about. And I decided to stay on for my PhD. So I was lucky enough to be able to kind of continue on in grad school. And I came on funded through a research project that we eventually called PASS, or the Preventing ACL Injuries in Soccer study. So I'll talk more about kind of what that looked like, and what we found a little bit later on. But this is just to say this was really the intro for me on working with a variety of different community organizations across the state. So over the course of a couple years, we worked with 4 different youth soccer organizations. And it was just a really interesting experience and kind of seeing the similarities and differences between organizations when I'm trying to implement the same intervention, but it looks a little bit different depending on where I am and who I'm working with. So kind of those 2 experiences together, towards the end of my PhD, I kind of started taking a couple more public health related classes. And this was really because, as I was saying, it's supposed to be the same intervention, but we're working with different organizations and it ends up looking a little bit different. And we're running into, in some cases, the same barriers between different organizations, and in other cases, very unique considerations for that setting. So the public health degree just really helped me find ways to kind of contextualize those differences, to measure them, and to try to address them systematically through research. Right? So all of that happened. And then what I wanted primarily was warmer weather. I know you all are in Vermont, so colder than Connecticut, but as a Southerner, it was too much for me. So there was a postdoc fellowship at AT Still University, which is actually the campus I was on is here in Arizona. But the focus for me during my postdoc was on pediatric sports medicine. So I was able to work with the Sports Medicine Advisory Committee quite a bit. And if you're unfamiliar with how a sports medicine advisory committee works with a state, the Arizona Interscholastic Association, kind of like the NCAA, but for high school sports in the state of Arizona, they have a sports medicine advisory committee. And this committee is made up of like physicians, athletic trainers, physical therapists, that kind of thing. And they all kind of come together to make health and safety policy recommendations that they think the AIA should adopt. So this was a really great experience in kind of working with different stakeholders like administrators, more work with coaches, but in a different capacity. So looking more at like policy development. Athletic directors, if I didn't already say that, they're very involved with working with the AIA. And then of course, other healthcare professionals. So the physicians, the neurologists, that other athletic trainers who work in various settings. So that was a pretty interesting experience for me, just kind of looking at policy change kind of with all of those people in mind. All right, so where am I now? I'm at Northern Arizona University, but their Phoenix campus. So it's normal, their main campus is in Flagstaff, which is actually in Northern Arizona. If you're not familiar with Western geography, Phoenix is in a valley and it gets very hot here. But this is Louis the Lumberjack, in case anyone was wondering. Okay, so that's me, athletic trainer with an interest in a public health population level perspective. And I just want to talk a little bit more about how kind of these two different fields inform each other. All right, so first, just starting out on what is public health, and thinking broadly about the definition here. You know, it's meant to promote and protect the health of people in the different communities where they exist, right? Where they live, learn, work, and play. And to take this population approach, I think sometimes people can think that it doesn't mesh with a healthcare professional who is providing individual treatment to their patients, right? So clinical health and population level health have two different kind of focuses and tools that they can use. But if we look at the athletic training domains here, so here are kind of the 6 primary domains that athletic training education encompasses. And if we compare this to what public health is really broadly, there are a lot of areas where they overlap. So a big part of athletic training is prevention. My research line and interest is really in this injury prevention arena. So how can we make a prevention intervention or effort that addresses a whole community that I'm working with, rather than you can also tailor it to an individual level, but if I want to make like a team level impact or a school level impact, how can I get more people involved? So that's kind of taking a population approach to prevention. And then when we talk about kind of emergency care, that organization and administration side of things, this is when we're starting to talk more about policy change, which is a huge part of public health. So how can I get everybody on the same page so they feel like their voice is heard when we're creating this policy? And what can I do to ensure that people have the tools and resources that they need to be able to implement that policy the correct way at the right time? So that's kind of the connection between athletic training and public health. If this is an area that you're interested in, I guess highly suggest this resource here. This is kind of just a summary document from a couple years ago, where a group of athletic trainers kind of came together to more specifically talk about these linkages between public health and athletic training. And so this is kind of just a really nice document that outlines it. But what I want to draw your attention to is a figure they have in this document that's just very generally proposing a kind of population level public health approach to addressing any kind of injury or condition you might be interested in. So we have like this step 1 where you're just trying to, this is really the epidemiology research side of things, right? Can I track the incidence of a particular injury or condition? You know, how many people does this impact? How frequently? And then the burden of a particular injury or condition. So, you know, what does the rehab look like for this injury? Is it really expensive? Is it a really long process? Does it have, you know, particularly negative long-term effects? And then, you know, what's the, yes, financial cost, but if somebody's out of work, what's that cost related to their quality of life and any kind of lost income? So a lot of different ways of describing the magnitude of the problem that epidemiologists are very good at, right? So once we know that a problem is truly a problem and the magnitude of it, then we can try to find ways where we can decrease that issue, right? So a way to do that is trying to find these risk factors and mechanisms that cause that problem. So I'll talk about this kind of for the rest of my presentation afterwards, but I'm really interested in lower extremity injury prevention. So we have really particular injury risk factors that are related to ACL injury and ankle sprain, and they're all pretty similar. So we can have one intervention that addresses these risk factors that positively impacts somebody's injury risk for a lot of different lower extremity injuries. So once we know the injury risk factors and mechanisms, this is kind of where I do most of my own research, and that's in the world of like, how do interventions go when we try to implement them? So if we've identified the risk factors, how do we design an appropriate intervention that's going to target them? And then once we know an intervention works, how do we get people to do it, right? That's really kind of the crux of what I'm interested in looking at. And then just a quick thing here, which I don't know, I might get on a soapbox about it later, but here when we have this efficacy versus effectiveness, I don't know how familiar you guys are with like the nuance between these two things, but efficacy, we're really looking at, how well an intervention works under ideal controlled circumstances. So this might be in like a lab setting, where we have, youth athletes come in from the community and we run them through all of this equipment that we have in our biomechanics lab. And so we're very sure that it works, but all the equipment we're using is very expensive and bulky, and not everyone has access to it. Versus effectiveness, this is when an intervention is really going to work in the real world. So does an intervention work not when a researcher is implementing it, but when your end user is implementing it. So when a youth sport coach does an injury prevention program, does it still work? So that's kind of the direction we're moving in here. Okay. So why is taking this stepwise approach important for research? And so on the left-hand side here, we've got bench research. So this is, I think, what a lot of people might typically think of for research. It's like very lab coat driven. I'm at like a clean white bench top, right, with pipettes in my hand. So we have kind of like the basis of research. This is when we're trying to figure out mechanisms. So injury risk factors, things like that. And then we have the real world over here, like our actual clinical practice. And unfortunately, it takes roughly 17 years for less than 20% of the research evidence to make it into clinical practice, which is just, right, millions of dollars are spent on research every year. But what's the use of it if nobody's using it, right? So how do we decrease this gap here? And there can be a lot of reasons why this may be the case. Potentially from maybe some of the other research talks that you've heard, you might have gotten the sense that, research just takes a really long time. By the time you enroll all of the subjects, and then you actually implement the study, and then you analyze the data, and then you submit it to a manuscript, that might be like a year. And then that peer review process to get your information out, that might be another year, year and a half of getting feedback from a journal. And then once your article is actually out in the world and people can read it, it's still going to take time for them to say, okay, well, this is suggesting that I change my practice in this way, but what am I currently doing? So you have to kind of teach people to de-implement whatever they're currently doing, and then to implement this new thing. And if that requires time to learn a new skill or money to buy new equipment, people are going to be a little bit hesitant to do that. And there are barriers that are going to come up to changing their practice. So all of those things kind of factor into this huge clinical gap that we have. So what can we do? A couple different things are suggested, and namely here, this top one in orange, having researchers who actually engage with the community. Right? So can you design your research studies with that clinician and end user in mind? So actually talking to communities and seeing what they want and asking clinicians what would be meaningful for their own clinical practice is really helpful, because if you can design that on the front end, then people are going to be more likely to adopt that and to use that in clinical practice on the back end. I guess some quick pet peeves with journal articles here are just that there are word limits on journals. And so a lot of times people cut context out of the methods. So if you were to read any journal article, if you've ever tried to like read through the methods and think to yourself, like, could I start to finish run this exact same study? I would say more often than not, the answer is no, right? People just don't provide enough information about how they did things. And then also there's this negative findings bias, where if you didn't find an effect, you're less likely to publish it. But it's also worth noting, if you publish negative results, was it because the intervention itself doesn't work? Or was it some function of implementation? Like, was it just failed? Did you just fail to implement it appropriately, so it didn't work? Or did you just not measure the right thing? It could be an evaluation change. So we need to find better ways of kind of tracking, measuring, and targeting implementation strategies in research. And so I try to do this in the youth sports setting. Okay. How might we do this in a methodical way? And I think a broad way of approaching this question is to think about which interventions work for whom, under which circumstances. And that's kind of how we're going to talk about youth sport participation and injury prevention over, the next 30 minutes or so. Okay. So athletic training and public health, we're really interested in youth sport and injury prevention. So first, talking about for whom. So other than the fact that I think youth athletes are funny to work with, why is it important to target this population? So when we talk about injury risk factors, the kind of 16 to 18 year age range is when we see a lot of ACL injuries kind of spiking, right? And we know that the incidence rate for ACL injuries is increasing in ages younger than that. So if we are trying to target a particular intervention, we might want to catch them before they hit these high risk age ranges, right? Can we make a difference before they get injured? Because if they get injured, injury from sport, they may not return to their pre-injury participation level. So if we see this attrition from sport and decreased physical activity level, you could really take that down the rabbit hole of what that means for long-term health and chronic disease development and weight gain and all of those things that public health is concerned about, right? So we want to target youth athletes. And this is actual footage from me working with youth basketball players. This is what they look like day to day, right? These are my baby giraffes. These are people who grew really, really fast and don't know what to do with their limb control, right? So how can we target them? Because if we have, I'll talk about it in just a minute. So we know we want to work with youth athletes, but which interventions work for youth athletes? And the interventions that we're going to target look at that movement control factor that we just saw in the giraffe learning how to stand, right? A metaphor that I like thinking about is if you think about your body as like a car, when we're looking at adolescents, a lot of times they get the gas before they get the brakes, right? So they have all of this like limb space, but they don't necessarily have the control to be able to move appropriately and they don't have necessarily like the strength. If they grew too fast, they might not have developed like the muscle capacity at the same time. So then it's just making their movements riskier for sustaining those lower extremity injuries. So again, we're seeing those higher injury rates in like the 10 to 12 age range. And that's really when motor development is at its peak and in this really critical point where we want to ensure those fundamental movement skills are in good shape and that they're participating in athletics. So a lot of times these injury risk factors that I'm going to talk about that are related to movement control, they're also thought of as kind of these developmental deficiencies. So here, this was a little bit exaggerated. You can tell by his smile trying to humor me in this picture, but we do start to see some of these sex differences through maturation, where kind of that knock-knee position that might put us in a higher risk for ACL injury and things like that. If anybody watches NFL football, Jameis Winston just tore his ACL, MCL. It was like non-contact-ish. Like it wasn't contact to the knee, but if you go back to that footage, it like looks gnarly. You can see where it twists. So we're trying to improve movement control to avoid some of those non-contact injuries that might occur. So how can we assess movement quickly and effectively in the field? When I talk about some of the more specific studies in a little bit, the movement control metric or variable that we use pretty frequently is this landing error scoring system. So here you're asking someone to jump off of a box and then immediately jump up in the air as high as you can. This is actually kind of the distractor jump because people get so focused on trying to jump up as high as they possibly can that they don't realize you're looking at their biomechanics at initial contact through max knee flexion. And that's what we're interested in. So I'll show you what it looks like in real time. So you have a camera on the front and the side. These are some of my youth soccer players, and you're just looking at their landing mechanics during this jump. I'll just quickly show what it looks like from the side. Right. And we have this scoring sheet with a number of different variables. And you're basically just going down the scoring sheet and you're saying, yes, no, did this person display an error? So by the end of it, you have a total sum score of how many biomechanic movement errors this person displayed during this jump landing task, right? So because again, those injury risk factors, so the more injury risk factors they displayed, the higher their landing error scoring system will be. So the more errors they have. So high scores are bad on the landing error scoring system. Okay. So that's how we'll kind of assess if our intervention is going to be targeting these injury risk factors. Now, what intervention can we use that's going to address these movement control factors, right? For here, I just put the National Athletic Trainers Association position statement on preventive training programs. In other kind of older manuscript or journal articles, you might see that they're called injury prevention programs. There was like this nuance shift at some point where people recognized you can't prevent every injury. So can we really call them injury prevention programs? So now they're called preventive training programs, but this should be pretty consistent from at least like 2018 forward. But anyway, I put the athletic trainer's position statement up, but also physical therapy has clinical guidelines related to preventive training programs. The Orthopedic Sports Medicine Journal has clinical guidelines. So these are like fairly common strategies for trying to reduce lower extremity injury. But what are they, right? And they look a lot like a dynamic warm-up, right? So 10 to 15-ish minutes. And the big thing here is that they typically contain these different components. There's not like a one-size-fits-all program here. There's a little bit of kind of artistic freedom with the designing a program. The goal is really just that it has these different elements in some way. And then the other emphasis is on feedback. So whoever is implementing the preventive training program, it's really important that they have a good idea of how the exercises should look, because you're trying to train strength and range of motion and flexibility in appropriate movement patterns, right? Because we're really concerned about movement control. So feedback is a big part of preventive training programs. So whoever delivers it has to be pretty confident about what they're looking for and what it should look like. So if you were on your own youth soccer field and trying to set things up for how it would look, you're on the sideline here, and generally for 10 to 15-ish yards, you have some dynamic exercise for your program, right? So that might be any of these different components related to plyometrics or agility or what have you. And then on this red to blue, right, X here, this would be a progressive. Question? No. Oh, okay. So from this red to blue, this would be a progressive jog. So in the beginning of the warm-up program, it's kind of a light run. You're just kind of trying to get into the swing of things. And then by the end of the program, this should be a full-out sprint. Like you're really preparing to participate in sport for the day. And then this blue back to yellow, that's always kind of that recovery jog back to the start. So that's generally what it looks like. When we talk about that real world effectiveness of preventive training programs, there's just a ton of evidence here that if you do the program correctly and consistently, it's going to reduce injury risk, it's going to reduce injury rate, and it's going to improve sport performance. right? So we have the evidence that this is going to be a good intervention to target those movement control patterns. Okay, so now we come to but under which circumstances? So broadly, preventive training programs can work, but if you have maybe an elite Olympic development program, girls soccer team, does their program look the same as 10-year-old adolescent boys playing basketball? Probably not. They have different needs, they have different circumstances. When I was working with youth soccer, a big barrier that coaches would talk to us about is like, I have limited field time. There are no lights on this field. And as we get closer to daylight savings, every single minute counts. I don't have the 10 minutes to do this program. I need my kids to be able to run straight into practice, right? Or if you start working with basketball teams, they're like, there's only one court, right? If we have court time, I need the full time available to me to work on sport-specific drills. So when we're approaching this question of under which circumstances, we can really think about this on, what are the barriers people are describing to me related to implementing this preventive training program? How do I prove to them that, it's not the case? I'm trying to improve their ability to be able to implement a program that I know will work if they just do it. So I want to focus here on this first one. So a common, I'm looking for a word gentler than complaint, but consideration that we frequently got was that, my athletes get too tired after they perform your program, so we just don't want to do it, right? And I would personally argue that if your athletes are getting tired after a 10-minute dynamic warm-up, they're just not in shape, right? And that's just got to be, that's like more of a reason to do the warm-up to me, is if they're getting tired after this 10-minute warm-up. But we wanted to double check, right? So we actually did a study where we were trying to look at the impact of an injury prevention program after a single session. So does performance change compared to other warm-up strategies that might be out there in one session? And so to do this, again, this injury risk variable that we were interested in, we looked at that landing error scoring system. And then we also evaluated some performance metrics. So standing long jump, vertical jump, and an agility metric. So what this looked like, they had a pretest. All of the athletes were randomized into one of the three groups, and then we post-tested them afterwards, right? So each of these warm-up programs was about 10 to 15 minutes long. It just differed in how it was delivered. Right, the dynamic warm-up was pretty similar to the preventive training program, except that the preventive training program had, again, those feedback cues, and it was just a little bit more specific to the components that you really need in a comprehensive preventive training program, versus this dynamic warm-up was really focused on like the flexibility component. And then the static warm-up, again, it was about 10 to 15 minutes long, but they just kind of, your classic, they sat in a circle and someone counted off stretching for 10 minutes. So what we found, here are the landing error scoring system results. So I know this slide is loud, but just orient yourself to the axes here. So we have our less score here. Again, the lower score is going to be better. It means they had less movement errors during the task. And here was that pre, where you see everyone's right around the same level here, regardless of warm-up group. And then we have the post-test here. And what you'll notice, if you look at the overall scores, this is only the difference of like a point-ish. So we could get into a separate conversation about clinical meaningfulness. But if we look at the stats related to this, you can see the static warm-up here, they actually got a little bit worse compared to baseline. Versus the injury prevention programs in the green, where we do see a decrease in that less score, right? So that's a great thing. That means immediately there was some kind of movement control benefit here that was positive. And when we looked at the performance variables for this, for the study, there really wasn't a difference between the different warm-up groups. So in an ideal world, to be really convincing about the benefits of preventive training programs, we might want to see like a huge benefit in an increase in performance variables from the preventive training program, but we can at least say it didn't make you worse. Sorry, I get a lot of robocallers. It didn't make you worse, right? Which was a huge argument from our coaches. So that was great. So then we know, okay, after a single session, I can work with the coaches and I can tell them, you know what, it's really not any different than whatever warm-up you would already be doing with your athletes, whether that's more static or dynamic in nature. So the next concern or barrier that we came across was with new coaches. So if we just take a second to think about youth sports, right? Maybe you can reflect on a sport that you played or have seen played in your past. The coaching experience at the youth sport, particularly the recreational level, it varies, right? It varies between, if that coach has actually played the sport before, if they've ever coached before. So frequently the coaches for youth sport teams at the recreation and town level, it's like a parent who really wants their kid to play. And if they didn't step up and sort of herd all of the cats and coach the team for their kid, there wouldn't be a team for their kid to be on. Right. So there's a lot of like, listen, I'm just here to let them participate in physical activity. Like I'm an accountant in the day. I don't know what you want me to do with preventive training. Right. Which is like, no negative feelings towards volunteer coaches, right? I think it's great that they're doing that, but it was a huge concern. They were like, I don't know where to start with this. I don't know where to find the resources to learn how to do these programs. So we spent quite a bit of time trying to think about ways that we can make preventive training programs easier for coaches. And one of them was that PASS study, would be redundant, but the PASS, Preventing ACL Injuries in Soccer study. So here we were trying to simplify the feedback cues that coaches would deliver, right? So we talked about how feedback is super important because we want to make sure that they're doing the movements correctly. But sometimes coaches would say, there's so many options, I just don't even know what to tell them part of the time. So what we did is there were a little over 400 youth soccer athletes, and we stratified them by team. So each team was assigned to a particular warm-up program, and it was either a simplified warm-up or a simplified preventive training program, a traditional preventive training program, or they were a control group. And we monitored the control group to make sure they weren't doing something like very similar to the preventive training program. And spoiler, nobody would warm up, right? There was virtually no warm-up involved if they weren't specifically doing the program for this study. And then the simplified and traditional warm-up, they were the same with respect to exercises. So they were the exact same programs. The only difference was in the feedback that we gave the athletes. So in the simplified warm-up, it was really trying to keep cues in the sagittal plane. So essentially it was like, just tell them to get low during all of the exercises. If we can increase this range of motion, I think we can build strength and improve their movement control. So we evaluated this movement control metric. We also added in a performance measure just to see if there was any kind of benefit with that. And the cool thing about this study was there were actually 4 time points. So we know that participating in a preventive training program, the more you do it and the more consistently you do it, there can be this added benefit to it. You can accumulate benefit from doing the program. So traditionally research kind of looks at that pre-post, before and after the season. But what happens if there's any kind of detraining effect? So how long do benefits last? If they improve from pre to post, how long will that last into the future if they're not performing the program? So this is kind of what it looked like. Again, we had a pre-test. We also did Y balance, but we had this pre-test during the first week or so of the season. Again, teams were randomized into one of these 3 groups. And then we had post-test during the last week or 2 of their season. So sometimes that varied, but typically we're looking at like an 8 to 12 week program. And then 6 weeks after the season ended, and then 12 weeks after the season ended, we also measured their landing error scoring and the standing long jump task. All right, so here's what we saw with regard to that landing error scoring over time. So just orienting you real quick, this like small dotted line is the simplified feedback program. And then the solid line is the traditional feedback program. So we can see everyone kind of starts around the same spot at pre, and the 2 preventive training programs at post decreased that landing error score, the less score. So that's good. That's what we want, right? A lower, less score means that they had less movement errors at post. But what we see is that, as time went on and they weren't continuing to perform that program, we're seeing these results kind of creep up to where everybody kind of is ending up around the same spot 12 weeks after the season. Interestingly, with the performance variable, we saw that the simplified program didn't really do much in the way of performance from pre to post, but the traditional feedback program had a lot more success at post with that particular performance variable. And they kind of maintained it for longer at this 6-week mark. But then at 12 weeks, everybody was actually worse than when they started at pre. A couple of different thoughts on kind of why that may be the case. So again, this happened in Connecticut, and most of these seasons were in the fall. So when we're talking about 6 weeks and 12 weeks after a fall season, this is when it was like snow time in Connecticut. And so people weren't participating in outdoor physical activity. So it was a steep detraining during these months. All right. So we wanted to kind of, after this study, so this was kind of a longer effort. This was over the course of a couple years. We worked with 4 different organizations. And we were wondering, for people who are new to coaching, does this exposure to a researcher leading the preventive training program? So for that past study, all research assistants implemented the warm-up. But we wanted to know, what if we can train coaches to implement the program? If the coach has seen it implemented for a season, does that matter with how well they're able to implement the program? So what that looked like, these experienced coaches, these 43, so these were coaches who had seen the program performed by the researcher the previous year. And then these novice coaches, they were either coaches from the control group teams, or they were just new to the organization, but interested in implementing a preventive training program. So we wanted to see, okay, during a season, if coaches are implementing it on their own, is there any difference between people who've previously seen it versus not? So we did one preseason workshop for everyone to train them on how to do the program. And it's not like a complicated workshop. It was maybe 2 hours in length, where you kind of talk through each of the exercises and then people practice implementing them. And then we looked at athlete outcomes from pre to post, right? So again, that long jump and then the jump landing task from pre to post. And here's what we found. So this was the season where researchers led the program. So there was that decrease or improvement in injury risk from pre to post. And then we looked at this second season when it was the coaches running the program. So if you'll remember, the athletes kind of went back to their baseline with that detraining. But then the coaches, regardless of if they had seen the program run before or not, the athletes improved from pre to post, generally speaking, right? So what does that mean? It means whether you've seen the program run for an entire season or not, if you attended the preseason workshop, you are capable of running the program successfully and getting the same benefit from your athletes as other coaches who had seen it run. So that's great news. That's great news. We know that regardless of the coach's experience, that they can implement it successfully on their own. So this last kind of barrier that we have encountered that I wanted to talk through was that sometimes for particularly the more kind of on the other end of the spectrum, for coaches who have youth athletes that are very competitive, we often got the feedback, the exercises you're prescribing don't apply to my athletes. Like they're not difficult enough. They're not sport specific enough, that kind of thing. So we, in particular, were working with this AAU league in Connecticut. And the really great thing about this organization, and I think something that plays into the earlier point of engaging the community, this AAU league approached us, right, as a lab. And they said, you know what, we had 6 ACL tears last season. Whatever you suggest we do to reduce injury, we will do it. And we were like, great, a captive audience. So buy-in was really important. And this was an organization that was willing to really embed this into the culture of their sport organization. So what we did is basically all of the athletes by team did a preseason preseason, what testing. Wow, couldn't find the word, guys. Testing. So we did the landing error scoring system. We did another agility and performance drill. And basically we looked at all of the movement control deficits by team. And we looked at kind of common themes. Do they all exhibit this particular error? Does that mean they have, maybe really low glute med strength or really poor quad strength, things like that. And then we developed warm-up programs for their team based on the injury risk factors that we were seeing in that particular team. And what we found was overall, so this is the change score. So the fact that it's going up is positive. I know I switched on you guys a little bit. So overall, everyone improved, and they did pretty well by over a point up to kind of almost 3.5 points, which is a pretty significant change with a less score. And kind of what we found is what we had anecdotally kind of noticed in previous years, that people who start off with higher scores, so if they have more than 5 errors at pre, they have more room to change, right? So they're gonna have the largest change scores at postseason. But even our low risk folks, they at least didn't get worse, right? So it wasn't negative for them to participate in this preventive training program, which was really great. All right, so what do we know so far? Youth athletes are a nice target population for injury prevention strategies. And we know that those preventive training programs can have all of these positive effects. And that's after a single session. That's if you simplify the feedback cues to make it easier for coaches to implement. Regardless of a coach's previous experience with preventive training programs, they can successfully implement them. And if you personalize them, you might even get more of a benefit than a generalized program that somebody might implement. There was one other study I was going to go through, but I'm low on time and I wanted to chat more. So I'm just going to move to future directions. Okay. So if we kind of reflect back on that research to practice gap, what do these findings mean for the future or different directions people can go in? And my suggestion is to just approach research with that population level perspective. Can I engage with the community? And am I doing research and work that's clinically meaningful for someone, right? Not just, do I think this question is cool, but like, would the results impact how somebody lives their life and their clinical practice at the end of the day? I just encourage, even no findings is a finding, and just trying to identify the journal that's going to still publish that is really important. And trying to answer questions that are in the form of barriers so that we can make implementation easier, and just make sure that people know that the evidence is out there and this is how they can implement it in their own settings. And just kind of systematically going through different barriers to continue to make implementation easier for folks is important. So I'll end on that with my main man, Freddie Freeman, and I welcome any questions.
Great. Thank you, Hayley. We'll give everybody a minute to put their questions in. I have a question while we're waiting. Sorry, Rachel, I see you have a question there. I'm going to sneak mine in first. So you showed that data that, once the program, when you follow people outside the program that they started, their numbers started to go back up in terms of their score. So have you done any longer term studies, or is there data to show, like, what can you do to really change the movement or the behavior to see long-term implications in terms of decreasing risk?
Yeah, I think that's a great question. I think the longitudinal study is sort of like the goal. I don't know that anyone's done that particularly well yet. There have been some, it was either out of like Sweden or Norway. It was in a European country where they followed folks for a couple years, and the programs continued to decrease injury rates. And as soon as the researchers weren't there, the injury rates skyrocketed back to baseline levels. I think anecdotally, what we've seen with some of the organizations that we've chosen to work with is that after we leave, there's like this champion parent who thought it was really cool and important, and then just starts trying to get everyone to do it and sort of like reminds everyone of the benefit. So I would love to do more work in trying to like dissect that down a little bit, like what changed and how were they able to create kind of this lasting change in their organization. But yeah, not as much yet, but it would be the hope, right? So I guess we'll just go in order with the chat questions too. So the first one was, how does someone get involved with the NATA? This is a great question. So the NATA has just started if public health is the interest, they now have a public health task force that is trying to kind of make these connections and build toolkits for educators and students and clinicians and preceptors and things like that. So there are different kind of groups that you can join that might align with specific interests that you have. I once got really overwhelmed with all the possible groups within the umbrella of like the NATA and some similar healthcare profession organizations. So I actually could share like a tree of the possible ways you could get involved, or different organizations and groups you could join within the NATA. But they also have like a student section. So there's like a student leadership section. And the National Athletic Trainers Association actually has districts. So I want to say Vermont is district 1 or 2. The numbers start up there, but that might be a more approachable way of kind of getting involved with the NATA, starting with either the state or district level, because you can kind of take more ownership over some different initiatives that they have, and then trying to find like national level involvement from there. Research applicable to all sports? I would like to think so. I know my mentor at UConn has worked a lot with youth ice hockey. Typically youth ice hockey players actually have like incredible movement skills because you all are in Vermont, but skating is less common in the South. Skating's really hard, and you actually build up like really great ankle and like glute strength from skating. But even with that baseline, there's still some room for just trying to optimize the warm up that people will do, and trying to, every sport might have different common like deficiencies in range of motion just based on whatever the repetitive motion is of that sport. So I definitely think there's ways of kind of incorporating injury prevention type programs into a warm up. For boxing's a little bit, so fighting sports are a little bit challenging because it's like, how do I prevent an injury in a sport that is like purposely trying to neurologically impair the other person, you know, when I'm trying to like build movement control patterns. So boxing, I would have to think more on, but I think it would depend on sort of, again, just starting with like that epi data of like, what are the common non-contact injuries in boxing? And then trying to see if you can intervene for some of the non-contact injuries that might be more common. I've had like rock climbers have reached out to me and trying to like build up a program for rock climbing. So there's like certainly ways to do it. It just might not look exactly like a soccer or a basketball program. So did we consider the socioeconomic status backgrounds of the youth athletes in these studies? No, but what a great way, like area to go in. We've started to foray into the way of kind of social determinants of health and things like that. Yeah, and then specifically, so youth sports in Fairfield and Greenwich are going to look really different than like middle of Hartford and parts of New Haven. And it's definitely a concern. We kind of the other side of this is, while I was at UConn, we were trying to embed ourselves a lot more into school systems and PE classrooms as well. Because, you know, definitely recognizing that not everybody's going to have the access or the financial ability to join youth sports. So if we want to kind of capture everyone and make sure everyone is physically active, a way to do that is through the school systems. So we have some preliminary data in that way, where it kind of matches some of the fundamental movement skill development literature where, you know, low resource, low access communities tend to have lower, kind of the more poor movement control compared to folks who have been in sport for a really long time or have engaged in particular activities. But if you're interested in that area, I strongly encourage it. And I definitely think it's an important direction to go into.
So Hayley, kind of working off of that question, what about other age groups? Does the data kind of look similar, or are you focused on youth sports because of, again, maybe bigger impact in the long term? Is there any difference?
Yeah, I think with youth sport, it's great because you're trying to capture them hopefully before any primary injuries have happened. And then again, if you capture the audiences where they have the most room to improve, you're more likely to find like an effective intervention that might work for more people within that subpopulation. So we've done some studies trying to compare kind of either late elementary school to middle school or middle school to early high school. And sometimes it like in general, it just depends, which I think is a little bit of a punt of an answer, but kind of depending on other factors that are at play. So we've tried to look at sports specialization behaviors and how that might play into injury risk patterns and things like that. But one of the things with youth sport is that as they're getting older, if they're participating in some capacity, they're likely building up some level of strength and movement patterns. And so as they're getting kind of older into middle school and high school, and then diversifying with different club sport experiences, or if they play different sports versus sports specialized, some of those variables tend to kind of cloud the movement control variables a little bit. Other thoughts? Great questions, guys. Oh, another one. How did you say you communicate with the public, like gaining awareness? Oh, gotcha. So the national, at least for the National Athletic Trainers Association, they have a research and education foundation. And one of the subcommittees in that foundation is structured to create information and toolkits to help with some of the research studies and position statements that have come out. It's really in its infancy, and I want to say the only they have, like, it was something related to maybe asthma or spine that's up right now. Like the resources are pretty limited right now, but I do think with the public health task force and kind of the awareness around trying to make implementation easier, more groups are trying to kind of figure out what those mechanisms are. Like, how do we get this information out to people? And whether that's like a social media campaign or just account that people can refer back to, or like the NATA Research Foundation having kind of like a central subsection off of their site where it's like, here are all the grant opportunities, but here are the tools for implementing the research that's already out there. So right now, I could also send along kind of the link to where that group exists. I think they're trying to put out more in the future, which would be beneficial. So maybe something to just kind of like check back with and to be aware of. But also from the Public Health Task Force, very open to ideas. So if anyone has thoughts on how kind of that translational science and that communication might be like ways to do it, I'm very open to thoughts and ideas. NATA meeting. So the upcoming NATA meeting, there's hopefully, barring COVID things, the first in-person meeting in 2 years is this summer in Philly, which New England geography escapes me, but that's like driving. It's aggressive, but that's like driving.
It's doable.
Yeah. Maybe if you had like a van full of people to like help with, but so the national meeting is going to be in Philadelphia. The regional meetings tend to happen in the winter. So if that's like an interest, I would definitely check out your district's or region's upcoming meeting. And then again, like the state level, I feel like state athletic training associations are always like would love help and assistance and interest in things that they're doing. And there's typically like student groups from each level of organization. So I would definitely try to look at the Vermont Athletic Trainers Association website to see kind of what things might be coming up. Communicating with me, if you guys want to send me an email, if you want to talk more, please feel free to email me and we can set up like a separate Zoom or phone call or whatever might be easier to help with any interests you might have. But that's probably the best bet, email.
Great.
All right. Yeah, thank you guys.
So
Appreciate
much.
it.
It's a great presentation. I really liked the connection with public health. So thanks for sharing all the work that you've been doing.